efforts for PathCheck Foundation. I'm Ramesh Raskar, professor at MIT and also founder of PathCheck Foundation. And today we're going to discuss how a digital pandemic response can allow us to prepare for future waves. We encourage you to join us on our website, pathcheck.org/India, and also join our Slack channel, tiny.cc/pathcheck Slack. And today I'm joined by our research manager, Rohan Sukumaran, as well as our project manager, Iman Shafi. If you think about the India second wave, the situation is very challenging. Just yesterday, we had the largest number of deaths. And as you know, because of lack of resources, the reporting of deaths and treatments are still underreported. And it feels like the second wave is also very different than the first wave because it's impacting younger generation. It seems to be driven by a new variant, even thousands of variants. You know, we are flying blind. There seems to be a shorter time for incubation, for infection and incubation, which is the day from which you're infected to the day the symptoms start showing up, or individuals may have to go to need hospitalization. And there seems to be higher need for oxygenation. So it's very perplexing. And if you look at the variants in Brazil and South Africa, they also seem to have behavior that's different than the virus behavior and virus kinetics in the first wave. So we seem to have two big challenges. One is just understanding the dynamics of the virus and the disease. And the second challenge is there something we can do about it? So one is about understanding and one about actionable insights. So at PathCheck, our focus is mainly on the digital layer, not as much on the physical layer. So it's not about creating more oxygen or creating more beds or fundraising for that. Our focus is on data-driven tools for foresights, planning, and citizen engagement. And we are working with many partners, you'll hear from them today, such as online pharmacies, e-commerce giants, crowdsourcing platforms, either launched by us or by others. And we think we can create enough data to actually create foresights, planning, and citizen engagement. This is an example that Shantanu Bhattacharya from Airtel shared with us of the impact of the lockdown from 2020. And just by using the mobility data coming from cell phone tower records, you can see that the migration from Mumbai ended up affecting rural areas in Rajasthan and Orissa and so on. And this is a very important piece of data because that allows us to see how quickly the disease may be spreading and how some of the resources should be redeployed, or the impact of lockdowns. And one of my favorite charts is, when we talk about preparing for the third wave and the future waves, it's not just about data, but how data becomes information, becomes knowledge, becomes insight, becomes wisdom, and becomes impactful. So it's not just isolated points, but how they connect with each other. And insights are really how do you connect the points that really matter, and the wisdom is how do you go from point A to point B, that's shown here in yellow. So we are really here for this data-driven insights. And at PathCheck Foundation, we think the main reason a pandemic response becomes inefficient and uncoordinated is because of the gaps in public health. So on one hand, we have test, trace, treat, and vaccinate efforts from public health. Then there's some notion of predicting and then some notion of alerting, but there are many gaps, as you can see on the left. And we think that crowdsourced citizen data can fill in these gaps, especially if we can provide privacy and trust by capturing, analyzing data from individuals, as well as providing the highly personalized engagement. So we are here to talk about capture, analyze, and engagement. So if you have Bala, who's a migrant in Mumbai, he might get exposed, he might have symptoms, he might test and isolate, he might get some treatment, he might even get vaccinated. But all this journey is invisible to the public health, most of this journey. So that's why we lead these data gaps appear. On the other hand, if you have Karuna, who's looking at this data, for planning from a public health or research point of view, she needs to know about disease spread. She needs to know what treatments are working. She needs to know where the next hotspots are. She needs to know if the deployment is happening in a equitable way, and so on. And that's why we need to think about these data-driven solutions. So today we're going to talk about 4 initiatives from PathCheck and others that will come up in conversations. The first one is you creating a Pulse Oximeter Network, and this is in collaboration with Makers Asylum and Airtel and Jio. Then we'll talk about online pharmacy. This is collaboration with 1mg and Mayo. Then the StellaVed, which has multiple entities engaged. And then finally, a massive effort we are supporting called Karuna crowdsourcing app. So when it comes to Pulse Oximeter, a Samsung Galaxy phone from S5 to S10 actually already has a Pulse Oximeter built into it. So the idea is straightforward. We want to create a pool of phone owners who already have the Samsung Galaxy phones and send them an SMS message saying they can become the good Samaritans and start helping people, especially if they're in remote areas and villages. And working through Airtel and Jio, our hope is we can, because these entities know who has which brand of phone, they can send a selective messages to these Samsung phone owners and separately and get them to register. And then separately for any patient who says, hey, looks like my oxygenation is low, where can I find the nearest pulse oximeter? We can tell them, who the closest people with Samsung Galaxy phones. And that's just the initial network. And that would create an early warning system so that, Makers Asylum and others who are already building high quality pulse oximeter at a very low cost through their setup in Goa can start targeting those particular regions as early hotspots. So we think it's a relatively straightforward effort. If you're interested in joining this project, it has some element of user engagement, some matter of web development, some data analysis, and of course working with Makers Asylum to actually deploy these physical solutions. The next one is our collaboration with 1mg, and I'm going to invite Utkarsh Gupta from 1mg and Santiago from Mayo Clinic to take it forward.
Thank you, Dr. Ramesh. Hi, everybody. I'm Utkarsh Gupta. I lead the data sciences here at 1mg.com. 1mg is India's largest healthcare platform and is basically an amalgamation of a variety of different services that allow users to take care of their health proactively from the comforts of their home. Can we move on to the next slide, Dr. Ramesh? Yeah. So as simple as we can put it out there, it's basically bringing care to everybody's health. There are 4 broad aspects of 1mg. The first one is healthcare information. This is something which is basically a big gap, which 1mg sort of took it on itself to fulfill. 1mg has information about medicines that are available in pharmacies that doctors are prescribing. There are a different variety of content like articles, bite-sized videos, as well as surveys on the platform through which users can actually get a more personalized experience about healthcare when they actually go through the platform. The second piece is the pharmacy platform, at the heart of which is a drug database and the entire supply chain, which enables medicines to be delivered at people's doorsteps from the platform itself. Then 1mg also has a diagnostic platform where we have a pool of phlebotomists that actually go to people's homes, collect blood and urine samples, give it to a lab, and the report is then given to the users in the form of PDF as well as a digital report. And lastly, there is a consultation platform, which in today's times has become a need of the hour, where everybody is sort of restricted to the confines of their homes and has to actually talk to a doctor through the other channels that are available apart from the offline channel. So with these 4 aspects of the company, 1mg is trying to sort of deliver a 360-degree experience for each and every user and patient out there. So here, at the core of 1mg, as I said, we have data and not just data, it's digital data. Over the last few years, we've been able to collect a lot of prescriptions from users for their medicine delivery. All of those prescriptions are digitized and we pull out medicines from them. There are around 3 million lab reports, out of which we've pulled out around 120 million digital parameters. There are e-prescriptions that are given by 1mg doctors. There are also e-consultations that happen. Around 5 million, a little more than 5 million users have created profiles for multiple patients on the platform. So it's an app which users can use not just for themselves, but also as caregivers for people that they want to take care of. The platform is available across multiple sort of devices, Android, iOS, desktop, and mobile, all towards the aim of making healthcare accessible, affordable, and understandable. Some of the key features of the platform are, as I mentioned earlier, medicine information, but within that, the ability to find substitutes of those medicines that have been prescribed by doctors and might not be available in the local pharmacies. So people can come on the platform and find substitutes for those medicines. They can also maintain their health records. They have pill reminders along with a lot of other variety of content like articles, videos, and surveys, as I mentioned. The primary user of our platform is a chronic patient that has long-term medicine requirements and has to sort of order medicines month on month regularly. However, during the pandemic, as people have not been able to go out of their homes, even patients with acute conditions have been coming on the platform and searching for acute medications. And this is what has led us to the analysis that we're going to show you. And I'll pass it on to Rajat, my colleague here, who will talk about the analysis between fever and searches and COVID cases. Over to you, Rajat.
Thank you, Utkarsh. My name is Rajat and I work as a data scientist at 1mg. So it all really started when we started looking at our searches on our platform and the daily COVID case rise in India. We categorize some fever searches based on some symptoms that the user might be searching or the medicines like paracetamol, Dolo, and other medicines that user might be searching for initial COVID treatment. So we plotted these two parameters and we found out that there's a really high correlation, especially, and we plotted this for a single city, New Delhi, and the graph you see is for New Delhi. There's a high correlation for the searches and the COVID cases that are trending in India, and the correlation is somewhat close to 1. As you can see, as Utkarsh mentioned, that 1mg is particularly a platform for chronic patients who come for diabetes and other chronic illnesses. The fever searches are quite low at the start, but as soon as we move to the first week of April, the searches boom, and so does COVID, especially in New Delhi in the second wave. So one of the questions that we had to answer is whether we can use this as a predictive indicator and especially a leading indicator so that we can probably predict COVID cases in the future and use this data for some meaningful purpose. Doctor, can you please switch to the next slide? So here we plotted heat map of COVID cases and searches on 1mg. As you can see, the timeline of the graph here is from 1st of February to till date, and red spots kind of show how the higher intensity of both COVID cases and the searches. If you might play it again. Yeah, as you can see, the COVID cases kind of start peaking in first of March and probably move in the Maharashtra region and how they migrate to the northern region, and in the end they have quite a progression towards the eastern and the southern region, which might give us an indicator of how the COVID cases are moving across boundaries and across directions in India. And the searches heat map gives us a pretty good indication that we are able to see some patterns originating beforehand when the cases are coming. So for an example, as you can see, Mumbai starts peaking early and the cases come there, and the peak explodes there first. And the same is for New Delhi and Kolkata. So this gives us quite a good indicator on how we might be able to use this data and predict any hotspot or any booming area in the future in terms of COVID. So can you move to the next slide? So here we plotted some fever searches for major cities of India. And this is a week on week plot of number of searches that happened in that particular area. The bold demarcation gives you an idea of where the peak lied in terms of the weeks. So as you can see in the column from rise to January to early April, this gives you an indication of what has already exploded. And the second column gives you an indication of what is currently in process to become a next hotspot. So let me just explain it with an example. Let's say Kolkata. Kolkata had a 196% increase from January to early April, while there's a really high increase in the late April column. So there might be an indication that cities like Chennai, Kolkata, Visakhapatnam, Bhubaneswar are probably going to peak in the future. And we might need to allocate our resources or efforts towards these regions. And as you probably kind of inferred from the heat map, there might be actual evidence to this data that how the searches are peaking and how we can use this data to probably take some actions in the future. So right now we just looked at the fever searches. I would like to pass on the mic to Nitai, who would probably go a little more deeper into the different kinds of medications and different kinds of salts that might show a pattern. Over to you, Nitai.
Thank you, Rajat. Hello, everyone. I am Nitai. I work as a data scientist at 1mg. So as Utkarsh and Rajat mentioned, that we do get a lot of traffic where people are searching for medication, and as well as we also have facilities to be able to track a particular user and his or her journey across the platform. So that being said, we also bifurcated our searches related to fever and kind of aggregated them into separate, so to say, types, which can represent the severity of the disease that is there currently. So just to give you an example, the data that we had, a similar data was bifurcated, the search data, into say 4 different categories, which pertained to either medicines or direct searches related to antibiotics, vitamins, which you can say are used in relatively early phases of the diseases, and respiratory and steroid-based medicines, which are generally for more severe cases. So as you can see from the curve here, what we notice mainly is that the red and the blue ones, which are generally used to treat mild COVID symptoms, we saw an increase in the search volume from starting from second week of April, and the similar increase was seen in the third week of April for respiratory and steroid-based drugs, which means that the disease had already gotten to a severe stage within the country. So the idea is to utilize these markers to be able to derive the severity or the progression of the disease within that wave as well. So can you move on to the next slide? So just to add to what I told, and as I said, we can track a user's patterns or searches on our platform over time. What you see here is a curve where we have plotted how a user has migrated his searches from being in a category of mild to a moderate to a severe COVID symptom or a medicine. So for example, if I take a blue curve here, it represents the percentage of users, week on week percentage of users over the entire nation who have moved from a mild COVID-related surge to a moderate COVID-related surge. And as you can see, with time, when the number of COVID cases increases, the percentage of people who actually migrate from a mild surge to a more moderate or a severe surge, they also increase with the number of cases. So this in terms also gives us an idea or a precursor of the severity of the disease that is happening, which can be due to multiple factors as well. One factor being that the virus strain itself being more severe, or the healthcare infrastructure within the country not being able to cater to the number of cases, boiling down to more severity, which is actually the case and is being shown in the data here. So to sum it up, the kind of data analysis we have done and the kind of raw data sources we do have, we do feel that a lot more can be done. And Professor Oscar, can you move on to the next slide? Yeah, so Santiago.
Yeah. Hi, I'm Santiago.
I'll let you introduce yourself.
Yeah, thank you. I'm Santiago, I work at Mayo Clinic. I'm going to talk briefly about the data sources that we have and the next steps that we plan to use this data for. So, sorry. From 1mg, we have search data that we have by location and account. People can search based on their city. And then we have medication search based on that. But that is as granular as that data gets. Then we have the other piece of data, which is prescription. So patients can come in and get a prescription through the system. And that one has information by patient. So we have some demographics about them. Particularly, we're interested in age and gender. And then it includes a chief complaint for the prescription. And then we're working on getting survey data that the users can respond to when they see the little banner on the web page. We're hoping to get a bit more specific information about COVID through that survey data. Next. Yeah, so next steps and next questions that we're trying to answer with this data are related to the disease dynamics. So we are trying to answer what is the symptom trajectory. This is information that as Ramesh mentioned, it may be very different in the current variant of the virus. And we can track some of those symptoms, as we mentioned, from mild to moderate to severe. We plan to do this by specific user to see how many patients transition to, or how many users transition from mild symptoms to moderate. What is the percentage there? And what is the time? Because it could be that the time is much shorter, which would then inform how much lead time we have when we start seeing a surge in mild symptoms till we see a surge in severe symptoms with people needing potentially oxygen. The other question that we're trying to answer is what fraction of family members get infected. We know in the previous version of the virus, there was about a 25% chance that another family member would be infected if one member of the family was infected. But this may be very different. This may be much higher, or maybe people are being much more careful, and then it can be much lower. So we plan to get this information using survey data. And then the other question is looking at the age group that is being affected, and then how comorbidities play a role into this. This is something that we can also get some insights into, both from the survey and maybe from prescription data. I'll pass it on. I think we have the next section there, so I think I'll pass it on to Ramesh.
Yeah, thanks the 1mg team and the Mayo Clinic team. And this is highly confidential data from 1mg. So we'll continue to get more progress as time goes on. So please use the chat here if you're interested in working these projects. Join our Slack channel, the data science team as well. Next we have from telehealth team for teleeducation.
Hi, this is Swami Iyer, Professor of Medicine from MD Anderson. Thank you for the opportunity to talk about teleaid. Teleaid is teleconsultation or teleeducation. There has been a deliberate use of the word education as opposed to consultation for various reasons. As you all know, there's a huge situation with the patient care, the doctors are overwhelmed, the entire medical community is overwhelmed. And could we serve as a sounding board for some of the complex patient care issues? And there are, at least in the situation with India, there are close to 100,000 doctors of the South Asian origin who could potentially be of help and willing to help, cannot do anything, but from a distance, is it possible to do it? So that's how this whole idea came about. And you also probably have heard about multiple platforms out there doing this and doing direct contact with patients. There is a little bit of hesitation around the legal framework, but this, we were very fortunate to have the connection with Teledoc, which is a UK-based daily platform service that is currently utilized by the National Health Services in UK, and it is also used by the insurance agencies in the US like Cigna and Aetna and several others to have the doctor-patient call. So they have a very well-tested platform, which is HIPAA compliant, and they are able to do audio and video. And so you can see that this whole tele platform that came through the discussion has to do with this ability to connect with the physicians at the ground level, or even the ASHA workers at the ground level, between the doctors here or the nurse practitioners here. There have been an outpouring of support. We have at least 150 doctors who have signed up to do this teleconsultation at various time points and time zones that would allow this conversation to. And you can see in this element 7, and it advice is based on condition. And as you know, even though the coronavirus affects 100 people, let's say it affects 100 people, it's about 20% of them who get hospitalized, and it's the 5% who are really sick. And there's a challenge, and the situation in India is such that you have a resident or a postgraduate taking care of 50 to 100 patients at any given time. Is it possible for us to help them doing rounds and also to answer the questions? And it lowers the pressure. There's somebody for them to call, pick up the phone and talk to. And next slide, please. Okay, thank you. And this team, as I mentioned, is set up through negotiations with Teledoc. Dr. Rajiv Gupta from MGH, Harvard, is a radiologist. Mr. Rajesh Makhija from Gestalt, and Dr. Priya Ramaswamy and Dr. Myself and many others actually were able to get involved in this discussion. And you see the 120 plus clinical volunteers from the USA who signed up. It's a collaboration between CARE Inc., which is another NGO, which is called a Collaborative Action for SARS-CoV-2 Eradication, and with PathCheck Foundation. So CARE Inc. is managing this and has a legal framework, has vetted the legal aspects of this, and PathCheck is running this, and the Teledoc is a provider, and the participating hospitals. So one of the unique thing about this platform is that there is a connectivity at the local level. There's a personalization, as opposed to doing this broad-based across the country. We have connections with hospital systems and with district hospitals through the district collectors. For example, in Maharashtra, we have this KEM connection with Mumbai and the district hospital in Ratnagiri and a private hospital in Ratnagiri. And so the advantage there is that you know who the people are and they can call you at any given time and discuss about the patient situation. Similarly, it's a scenario in Bangalore with Boring and Lady Curzon Hospital, which is a government hospital, and the district hospital in Chikmagalur through the district collector. And we are going to go live soon, and that is today as we speak. All the documents have been set in place, and this is the purpose of TeleRate. Eventually, I think once we get the legal framework set, this could also be extended to the patients, through the ASHA workers. As you all know, the ASHA workers at the ground level are the ones that are contacting the patient. Another advantage of this platform is you've talked about data collection and the crowdsourcing. And one of the ways that this TeleRate can also help with data collection and crowdsourcing is for us to get the help of ASHA workers, and also the conversations that we have that can be recorded and data mined for some of the queries that we all have through Corona surveys and various things. So I think there's multiple ways to go about it, but thank you for the opportunity to work with PathCheck and several other NGOs to make this possible. Thank you. Right over to you, Ramesh.
Dr. Swami, very briefly, what help do you need from folks here and otherwise?
Thank you. I think as listening to 1MG and several other organizations, the data collection, if there is a way to make this integration happen with the data collection, we would, because data is one of the biggest drawbacks in India. If we can use this platform, they can talk to us to make this happen. We'd be eager to talk to them.
Fantastic. Thank you so much. It's amazing to see, we have doctors from Harvard, MD Anderson, UCSF, from Florida, all coming together. Very exciting. Another great thing that's happening in India is, we have a lot of teams coming up and providing real-time solutions for bed availability and hospital availability and so on. And so it turns out many of these teams actually are good friends of PathCheck Foundation. So COVID Citizens, run by some really fantastic group of people. They're in touch with us. India Shield, which is run by a team mainly out of Mumbai, and our friend Yashraj Akashi is our contact. So we're trying to help these teams as much as we can from PathCheck. Again, given that our focus is on software and data. More specifically, though, a really fantastic opportunity has come up because 3 alums from IIT Delhi, Milan, Praneeth, and Swapnil, started really early, and they already have about 24 million users, mainly in the Delhi NCR region. And so they proposed to us something that could go, really broad. So I want to invite Iman as well as Milan to take us through the next set of presentations.
Awesome. Thank you so much, Dr. Askar. So hi, everyone. My name is Iman Jafi. I'm currently working with PathCheck. It's a volunteer opportunity, and if everyone is interested, please use the chat to ask questions as well. So Karuna was started as a resource allocation application, because we've seen that during the pandemic, there's a lot of uncoordination, especially for resources such as beds, oxygen, plasma. People don't know if the resources have already been taken or not, and where those resources are allocated. And so the objective of Karuna was really to start off an app that integrates not only the current resources, but also asks hospitals, admins, doctors, etc. in India to access the web app and to put up approved and verified resources location. As such, the Karuna app was started, and we were even able to integrate some surveys to contribute for the effort, where we've actually been starting to get a lot more data from individuals, data relating to COVID, symptoms, age groups, but also state, which is very important to predict the future hotspots. And so to continue, I'll bring up Milan, who started off as the COVID relief app, and he'll be able to discuss a bit more about how the idea started and the COVID relief switch to Karuna as well.
Yeah, thank you, Manik. So hi everyone, this is Milan. So I, along with Praneeth and Swapnil, we started this app named COVID Relief on 22nd of April. So the idea was simple, that we wanted to aggregate data from several authentic sources and help people track down availability of beds, oxygen, plasma, and so on. So as you can see, so currently we are tracking beds, oxygen, plasma, food, and other sources from 40 different cities. Along with this, we have also done several other things. For example, we have partnered up with a volunteer organization named COVID Survivor Force India. So what they do is they help people through social media channels, so anyone can put up their requests on these channels, and our volunteer network helps them. Secondly, we have developed this statistic named as city stress meter, which is a function of active cases in a particular city and the vacant beds in that city, which sort of gives an indication to how much load there is on the health infrastructure of a city. So this app has been used by more than 25 million people till date, and we have got hundreds of mails and mentions on social media as to how people were able to find resources through this app. So I believe we have definitely been able to help save a few lives. But with help of PathCheck, the idea is to take this app to the next level, because I believe Cove Relief and other such initiatives perhaps would have ended whenever the wave 2 of pandemic ends in India. But with PathCheck, the aim is to create a self-sustainable, long-lasting app which helps India not just through this wave, but through future waves, and not just through COVID, but perhaps any sort of disaster which India faces. So, so Imane would be giving a brief demo of the Karuna app, but just to give an overview of what Karuna is going to be about. So, so this would essentially mean involving government, hospitals, and so on to provide crowdsourced data. So currently there is no channel of communication between, let's say, a city administration and citizens. So let's say I am a district magistrate and I want to lock down a particular area of city. So unless citizens live in a Delhi or a Mumbai, there is no way for people to get such information. So through Karuna, at the tap of a button, an admin would be able to broadcast such messages, not only with respect to lockdowns, but with respect to vaccine availability, or let's say launch of a new 100-bed hospital and so on. So this would enable very clear communication between the government and the citizens. Secondly, every hospital and other providers would have their own dashboards where they can update availability of their resources. So right now, the only channel of communication between a hospital and the citizens is essentially a phone number, which is creating a very high load on the infrastructure, because the same number is being called thousands of times from patients, right? So if hospitals have a way to reach out to the citizens and directly update the availability of resources and all the facilities they provide through a central dashboard, that would reduce the load tremendously and would be very useful for the users, because in a panic mode, you won't have to call thousands of numbers. So Karuna aims to solve these problems along with several other problems. So I would like to thank Dr. Raskar and the entire PathCheck team for helping us do this. And over to you, Mane. Looking forward to the demo.
Awesome, great. Thank you so much. If we could go to the next slide. Yeah, so this is, if you could start the video and also put it full screen, please. This is the current prototype for the Karuna app, where you can select your state, district, and have resources based on your state, district, or even PIN code. And when you enter the app to look at different resources, you can do so based on hospital. The surveys are also present on this same app, where everything is currently in an app, in a React app, a web app, but we are also currently working on moving it to Android. There will also be a chat option where you can chat with hospitals, and hospitals will be able to pin messages that are very important. However, to chat with hospitals, you would have to create an account, but all of the resources and also looking at the previous chat is available without creating an account as well. For accounts, we have different types of accounts. Accounts for hospital admins, accounts for city admins as well, but also accounts for normal members who would like to chat with the hospital. There is the possibility of adding a suggestion if you are a hospital admin or a hospital doctor, a hospital nurse as well, and those leads would be presented as well on maps. So the maps would be very easy to look at. When you create a new lead, you can create for different types of resources, the locations, and the different messages to be added to the location, such that those verified leads can be seen on different districts by individuals and have it as soon as possible. So this is very integrated within the app, having the surveys, the chat, and also some broadcast options. So for example, city administrators would be able to use the app to give out live broadcasts to anyone that's using the app, either as an Android app or as a web React app, and to see, for example, if there's an outbreak, as soon as possible, the city admin would be able to give a broadcast through the app. So these are some of the very interesting features that we're currently working on. And, you know, we're always looking for more volunteers to help as well with the research, to help also with the surveys. The predictive modeling team as well is also working towards getting more members involved. If you are interested in working in this initiative and helping to optimize resource allocation, we really encourage you to join our volunteer effort, join our Slack. And this currently is being developed by volunteers. It's currently being developed by developers who are giving their time. And if you're interested in working in this as well, please check out our website. So there's PathCheck/India, PathCheck.org/Karuna, and also check on our Slack. That would be very helpful. Thank you everyone for listening, and back to you, Dr. Iskar.
Fantastic. Thank you very much, the whole team. As you can see, there's a lot going on here in various initiatives. And I think it's important to realize that although we mentioned these 4 major initiatives, Pulse Oximeter, collaboration with WAMG on their data, telehealth, education, and Karuna, and the key hypothesis is, again, that the data gaps, the gaps in understanding the progress of this pandemic is the main reason why the public health response is uncoordinated, inefficient, and that's what leads to all the suffering and deaths and impact on the socioeconomic fabric. So we are here to solve it with data, and we're not just here to write papers. We have some fantastic papers coming out from our collaboration here in top journals, but we also want to make an impact in the short term. So if you're a volunteer, if you're a professional, if you want to join our team, let's do that. We'll take a couple of questions coming in on the channel right now, and then stop there. So first question here to maybe Milan and Iman is, what's the strategy for dealing with non-English languages?
Yeah, there was actually a discussion about this with the volunteers, and another one of the founders, so there's currently 3 founders for COVID relief, Milan, Swapnil, and Praneet. Swapnil was able to create a Hindi version of one of the surveys, and we're looking into creating an Hindi version of the app as well, such that it can be read in English and Hindi, and hopefully also getting other languages and possibly French, more languages as well. So this is what we're looking forward to. We are setting out for volunteers that do know different languages to help also with the translation. So if you know different languages, would like to collaborate, check out on Slack for volunteer opportunities.
And if you see the PathCheck's contact tracing apps from last year, we had volunteers from so many countries, and the contact tracing apps in our GitHub were translated in 15, 20 different languages by volunteers. So hopefully we can start a similar trend here for the Karuna app as well in the PathCheck GitHub, which is one of the world's largest open source nonprofit GitHub for COVID-19 solutions. There was a question about prediction, and if Utkarsh or Santiago can talk a little bit about, what do we mean by next hotspots, and what's the accuracy we're talking about here? What are some initial, I know this early analysis, but anything you can share in that dimension?
Yeah, thanks, Professor Askar. Right now, all analysis that we've done is just as in a statistical analysis of the data that we have, along with the other variety of data from the 1MG platform, like searches, medication, page views, prescription data as well. What we found is there is a leading indicator that's present in these additional data sources. So we haven't really gone and predicted something as of yet, but the initial statistical analysis does give us good hope that something can be done in the future. Santiago, would you like to add to it?
Yeah, so I think the idea would be if we can, sorry, let me gather my thoughts for a second. The epidemics don't happen all over the country, right? So and we saw in the map the different temporal and geographical trends. So as Oktash mentioned, if we can look at leading indicators in different locations for surges, we can expect a surge in the number of hospitalized patients in that location in the next, and then we don't know yet how many days, but in the next few days. That can give some of the public health officials and potentially also hospitals some lead time to react.
Yeah, I think this is still early. I mean, there's some good papers for retrospective data based on Google flu trends about how many people are searching for the word COVID or flu in Google searches. So we could also use some of the data. The challenge, of course, is how can it be prospective? It's one thing to fit a model going backwards in time. How do we do it, make sure that works going forward in time? It's going to be very interesting. So again, anybody has ideas on how we can get data at the village level or town level as opposed to just district level would be fantastic. There's a question here for which we may or may not have answer, which is, there's a rumor or there's a hypothesis that the next wave in India could actually impact, children. At least I have not seen any data to indicate that. At the same time, it's always a good idea to be prepared. I don't know if Tom Kingsley or Santiago, who are doctors here, or Dr. Swami want to kind of comment on that. Or what we should do to prepare for that, if it's true that the third wave might impact children.
Lost her crown or over, and she's had a lot of,
Yeah,
no, I don't think you're very audible, unfortunately. Yeah. All right, Tom, you want to go ahead?
Yeah, thanks, Ramesh. I mean, I think that would change the way we would approach dealing with COVID moving forward if this was true. Oftentimes we developed our prevention strategy around protecting the elderly. And I think if this was truly, a variant that was able to be more virulent in children, it would really change how we approach prevention strategies in our population. So it'd be, it would make a challenging pandemic more challenging.
Tom, I mean, more than the disease aspect, on the data aspect of it, anything we have learned from Brazil or previous pandemics going all the way back to the Spanish flu and so on, about changing in demographic and whether it makes sense to predict them using data?
Yeah, I mean, so the big goal in dealing with epidemics and pandemics is getting a head start, because most prevention methods in public health are involved with protecting your susceptible population from your potentially infected population, right? And this is where data is key. It always has been. I mean, one benefit of modern times is we have the ability to get data that back in the Spanish flu, they were often in the dark. And so I think, a lot of our technology now is really the new tool that we've never had before in a prior pandemic, right? And so harnessing the ability to get data early on will give us an upper hand in preventing spread. So yeah, I think we need to be creative about how we get this data in all demographics and all ages and in different locations with, different constraints in terms of, technology, in terms of ways of accessing data. But thinking through this now, I think is really important, not only for this pandemic. I think this pandemic still has a lot to go until we've, really addressed it. Obviously the vaccines have been a, really important part of dealing with it, but a lot of the world remains unvaccinated, and so we're still using these other prevention strategies. But I also think a lot of the tools that we're building now are going to be important in the future. We're more susceptible than ever for pandemics. I mean, our global population being, close to 8 billion, that we're going to start seeing more outbreaks than we have. And we've already seen that in the last 20 years. We've seen more outbreaks than we had in the prior 80 years. And so I think developing these tools are going to be important.
That makes sense. I see Antonio is here from the Karuna survey team in Spain, one of our collaborators. And, we're just hearing, that the countries neighboring to South Asia, like Nepal, are getting seriously impacted right now. Nepal had, just about 200 cases per day, and now they're approaching 10,000 cases per day in a tiny country of Nepal. And so I don't know if Milan, through your efforts, or Antonio, through your survey analysis of Facebook symptom data, is there something we can do for the neighboring countries in South Asia? Because I'm very concerned that India kind of has, was underprepared. Although things are getting slightly better, but neighboring countries could be under serious stress. And anything we can do from a data point of view.
Yeah, Antonio here. Yeah, let me share a video. Yeah, actually, we're working on we're using the survey data that the University of Maryland has been collecting on symptoms. And we are using it to generate estimates at the regional level for India, but since the scripts and the algorithms are the same, is automatically generating that for many other countries. And in particular for Nepal, we are already getting some data. Right now, all we are showing is at the country level, but we do have the data at the regional level, and we could identify. What we're working on right now is how to use this to guess or forecast where the new hotspots are going to be. And this is still going to take us a little bit of time, but estimating the incidence with a couple of days delay is already there, and you can share it with anybody who's interested.
Yeah, that's fascinating. Anybody wants to take a Milan? Go ahead.
Yes, I think from a short-term perspective, once we do sort of a pilot of Karuna in any city, this thing can be deployed to neighboring countries like Nepal, especially because the demographics and everything is sort of similar. The variants there may not be much different. So the sort of analysis which is being done for India, similar analysis can be valuable in those countries as well. So this Karuna can definitely be deployed in the neighboring countries once we are sort of through a pilot for this.
Yeah. I mean, the biggest concern right now is that India, being a somewhat middle-income country, was able to handle rapid deployments of oxygens and hospital beds, but low-income countries could be severely impacted if they are not prepared. So with that, we're approaching end of the session. So I encourage folks to stay online for an informal conversation, but we're going to end our official recording of this thing. So Rohan, if you can just wrap us up, and then again, I encourage people to stay on after he stops recording.
Right. Yeah. Thanks, everyone. Thanks for this wonderful talk. It was a great discussion, and we look forward to collaborating with everyone over here. So I'm just stopping the recording, and we can continue the informal discussion.